Good afternoon, and good morning to you if you are on the West Coast. My name is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing, a project of North American Management. I want to welcome and thank you all for attending today's webinar, Presenting Quality Data to the Board, What Questions to Ask. This webinar is being recorded, and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, we will have a question and answer session. I'd like to say thank you to HRSA for allowing us to make this webinar possible through a grant national cooperative agreement. The mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. I'd like to get started and present our panelists for today's webinar. Michelle Layton has over 26 years of diverse and comprehensive experience in the clinical and business sectors of the healthcare industry. Her scope of expertise includes HRSA Health Center Program Management, Clinical Quality Management, Operational Analysis, Health Information Technology, Medicare, Medicaid programs, and federal regulatory compliance. Michelle specializes in program development and documentation of policies and procedures in various functional areas, including HRSA Health Center program requirements, quality management, federal and state regulatory compliance, Medicare, Medicaid incentive programs, and clinical software implementation and training. Michelle has extensive knowledge of HRSA Health Center program requirements, has worked with the Bureau of Primary Healthcare providing operational site visit assessments, as well as focused technical assistance to community health centers across the U.S. for over 8 years. Additionally, Michelle provides pre-operational site visit services and interim leadership to community health centers nationwide. Michelle graduated with honors from the University of Rochester, where she received her Bachelor of Science degree in nursing, and graduated with honor from the University of Phoenix, where she obtained her master's degree in business administration. Michelle is an honorary member of the Delta Mu Delta International Honor Society in Business. Without further ado, I will turn it over to Michelle. Good afternoon, Michelle.
Great, thanks, Jose. Well, welcome everyone. I'd like to thank you for taking the time to attend this webinar today. Jose and I have been working hard to get you guys some more information as far as how to present quality data to the board and kind of what the roles and responsibilities are on each side, meaning the health center staff as well as the board. As Jose mentioned, I've been involved with health centers for over 25 years, and as I've watched the health center program evolve, I've found that the involvement of the health center board of directors has become more and more crucial to a successful quality management program. As an operational site visit reviewer and through my direct work with health centers, one of the trouble spots that I frequently encounter is a lack of understanding about the roles and responsibilities on the part of both the health center and the board as it relates to the presentation and receipt of quality data. Throughout the next hour, what I'd like to do is provide you with a little bit more information from a reviewer's perspective. And if you take a look at the agenda, you'll see we're going to do an overview of the HRSA clinical quality requirements relative to the board of directors. And what I mean by that is, what is the board's role with a number of the clinical quality requirements in the health center program? We're also going to take a look at the board's role in receiving clinical quality data, as well as the health center's role in presenting clinical quality data. We're also going to take a look at some factors that you should really consider when gathering and presenting clinical quality data. And we're also going to talk about some strategies for presenting clinical quality data. And then we'll have a brief question and answer session. So I thought it would be beneficial for everyone if I did an overview of the HRSA clinical quality requirements that the board of directors really plays a role in. The HRSA requirements for clinical quality reporting are outlined in the federal statute, but compliance with these requirements is evaluated through the operational site visit. I always tell my grantees to use the operational site visit guide as your tool for evaluating your compliance and as a tool to identify where you may have some gaps. The operational site visit guide is essentially an open book test because you have access to the same exact criteria that I do when I perform an operational site visit. Compliance with clinical quality reporting primarily falls under the following health center program requirements. And in subsequent slides, I'll go into more detail about these. But program requirement number 3 being staffing, requirement number 8 being the quality improvement program, requirement number 15, program data reporting systems, and requirement number 17, which is board authority. And I just want to make a mention here that out of these 4 requirements, 3 of these are found frequently to be not met during an operational site visit. So program requirement number 3, staffing. I pulled this verbiage directly out of the site visit guide, so I'm not going to read through this. Essentially, requirement number 3 has 2 components to it. The one piece is the staffing component. So when I'm performing an OSV, I take a look at the health center staffing numbers and I make sure that they're appropriate for the services that are being delivered. But one of the pain points with this requirement is the credentialing and privileging component. And it's that piece that makes it frequently not met during an operational site visit. The credentialing and privileging piece also obviously falls into the quality arena, which is why I included it in the webinar today. I'm going to suggest that you always use PIN 2001-16 and 2002-22 as a resource for evaluating compliance with any board responsibilities for credentialing and privileging of your licensed and your certified staff. Now, PIN 2001-16 was the initial credentialing and privileging PIN, and Policy Information Notice 2002-22 was released as a clarification to the previous PIN. So if you look at PIN 2002-22, it talks about how ultimate approval authority is vested with the board of directors. It also states that the board may delegate approval of credentialing and privileging to an appropriate person via resolution or bylaws. I'm going to stress that you need to be sure any board approval of credentialing and privileging, your initial credentialing and privileging, and your reappointment of your providers every 2 years is clearly documented in the board of directors meeting minutes. And as we go through the webinar, you're going to see a common theme here that I keep stressing about documentation. And the reason that I'm doing that is because I frequently go in to health centers and they are performing credentialing and privileging according to the PIN, but then I look at the board of directors meeting minutes and I don't see any documentation to support that those providers are going before the board. Another reason why this credentialing and privileging component is so important is because it's attached to your FGCA coverage. You need to have a solid process in place that is compliant with the PINs in order to obtain and maintain your FGCA coverage. And just as a resource, I've included links to both of those PINs. While we're on the topic of credentialing and privileging, just a couple of reminders. The health center must have board-approved policies and procedures. So for my board members out there, if you haven't seen a credentialing and privileging policy come in front of you, you need to ask about it. The health center must have all of the documentation outlined in PIN 2002-22 to attest that all licensed and certified staff have the required credentials. When I go on site, I do a random sample of credentialing and privileging files. The health center must also conduct peer review between providers within the same specialty. So you'll see here the example I use is dentist to dentist or OBGYN to OBGYN. You certainly do not want your OBGYN performing peer review on your dentist. And one of the most important things is that this peer review must be considered in the reappointment process. And the rationale for that, from an FCCA perspective, is you want to be taking a look at provider performance and considering that as part of reappointment. So let's move on to program requirement number 8, which is the quality improvement program. Now this verbiage I also pulled out of the site visit guide, but we're going to go through this a little bit because obviously this is a really important requirement, and the board plays into this requirement pretty heavily. So the health center must have an ongoing QI program, which number 1 includes clinical services and management. So when I say that, I mean not only clinical performance measures such as evaluating blood pressures or hemoglobin A1C, but the QI plan also needs to have some clinical management metrics in there. So when I say this, I'll give you the example of patient satisfaction or monitoring no-show rates or monitoring ED readmissions. The QI program must maintain the confidentiality of patient records. So when QI information is going to the board, you need to be sure that it's blinded, that there's not any chance that any patient information is being released. The QI program must include a clinical director to provide appropriate oversight. Typically, I will see either a medical director or a chief medical officer as the clinical director who is providing that oversight, and possibly the director of quality or a QI coordinator is kind of doing the management and coordination of all the QI activities. The QI program must include routine and regular assessment of service utilization and service quality. So when I say this, I mean peer review, patient satisfaction, and evaluation of clinical performance metrics. I always tell grantees that I work with, I always suggest that they look at their UDS, clinical performance metrics, on a quarterly basis. And I know that sounds pretty heavy, but the reason that I tell them this is because if you're looking at your UDS clinical performance metrics on a quarterly basis, it gives you time to identify metrics that are below the benchmark and then implement a process for improvement prior to your annual UDS submission. And frequently, if I look at clinical performance metrics and I see they're below the benchmark, I'll go in and do a manual chart audit, and it's actually not a performance issue, it's simply a documentation issue. And lastly, the QI program must identify the need for an implementation of change when necessary. And what that means is that you're not just collecting data and distributing it to the board. What's happening is there's actually something being done with it. The data is being discussed, and then a process for improvement is put into place, and then changes are being made when necessary. And keep in mind that one of the board's responsibilities is ultimate approval authority of the QI plan, which is one of the reasons why I wanted to go through each of these criteria. So key language in this requirement: the results of the periodic assessments completed by health center staff must be shared or reviewed by key management staff and presented to the board of directors on a regular basis. So let's talk about program requirement number 15, which is program data reporting systems. So when we look at this requirement, it's kind of a collaborative effort between the fiscal consultant and the clinical consultant. We look to make sure that the health center has the systems in place to accurately collect and organize the data so that you can report the way that you need to report, and that you are sure the data is accurate and can be used for management decision making. I pulled some key language in this requirement out as well. There must be systems in place to collect and organize data required for your UDS and your clinical and financial performance measures. And once again, information from data reporting must be used to support management decision-making. So program requirement number 17 is board authority. And I have pulled some verbiage from the operational site visit guide out and placed it on this slide, but I've only included language that's specific to the clinical quality reporting, because as you all know, this is a very comprehensive requirement, and there's a lot more to it than just the clinical piece. I do want to make mention that when compliance with this requirement is being evaluated, it's a collaborative effort between all three consultants in each area, that being the admin governance consultant, the fiscal consultant, and the clinical consultant. So the Health Center Governing Board maintains appropriate authority to oversee the operations of the center, including, and as I mentioned, these are specific to clinical quality reporting, evaluation of progress in meeting annual and long-term goals, and that applies to clinical, financial, and operational, and involvement in long-term strategic planning through the receipt of appropriate information. So what that means is that the board is receiving QI data, it's being discussed, used for decision-making purposes, and then it's incorporated into the long-term strategic planning that happens. Key language in this requirement, and this is where you'll see the theme come through, these activities must be documented in the Board of Directors meeting minutes. I can't tell you the number of times that I go into health centers and they have this very robust QI program and they're doing all this reporting and presenting all this information to the board, and it's being discussed in the manner that it should be, and I don't see any documentation in the board meeting minutes. So from a reviewer perspective, if it's not documented, it's not happening. So let's talk a little bit about presenting clinical quality data and what the health center's role is in presenting that data. So the health center should determine who will facilitate the QI discussion at board meetings. As I previously mentioned, sometimes I see the medical director presenting at board meetings. It may be the CMO. There's some other factors to consider when determining who will facilitate that discussion, and we'll talk about those later in subsequent slides. The health center should also report or develop a reporting schedule for all clinical services and all clinical management metrics so that you have a solid reporting schedule and you know what metrics are being reported when. The health center should also present a monthly quality report, and as we talked about, engage in active discussion. Sometimes when I go into a health center, I'll see that a narrative quality report is actually distributed in the board packet prior to the board meeting, but when I look at the meeting minutes, I don't see where the report has been discussed. So essentially what's happening is the report's being distributed, the board members are expected to read it, and then sometimes I will see in the board minutes that the board members, they're just asked if they have any questions. And I can tell you that if that report is not discussed, board members probably won't have any questions. The health center should also present data in a format that's appropriate for the skill set of the board. We'll talk about this a little bit more in later slides as well, but you need to consider the skill set of your board members. You may have board members as well as health center staff that are more visual versus more narrative. The health center should also develop a training schedule to educate board members on these metrics, including all of the UDS clinical performance measures. I went into a New Start Health Center last year, and there was a medical director who took 2 UDS measures to every board meeting and did training and education on those metrics so that the board members understood why that was being evaluated. Based on that, I went back just within a few months later and attended a board meeting, and I found that the board was very engaged because that process had been conducted. The Health Center should also ensure that all discussion and decisions made are clearly documented in meeting minutes. And finally, encourage your board members to ask questions. If no one's asking questions, think about ways that you can encourage them to get involved in the conversation. Some board members are afraid to ask questions, and that shouldn't happen. So if you can kind of, as Health Center staff, if you can encourage them to ask, it will be to everyone's benefit. So now we'll talk a little bit about the board's role in the receipt of clinical quality data. And you'll see there's some crossover between these two roles, between the Health Center staff and the board member roles. But board members should always anticipate that a QI report is going to be presented and discussed at each meeting. So to my board members out there, if you're not receiving a QI report, you need to ask about it. And if the report is being distributed but it's not being discussed, you need to ask about that as well. Board members should always request training and education on the information that's being discussed. And board members should also always make sure that data is presented in a format that's appropriate for all members. As we talked about, the Health Center is responsible for presenting it in a format that's appropriate for the members, the board members, but the board members should expect that as well. Board members should always review previous meeting minutes to ensure the QI discussion from the previous meeting is recorded. I always get concerned sometimes that minutes are distributed and they're not actually read, and then the approval goes through. So be sure that you read those minutes to make sure that QI discussion is recorded. Board members should also consider the results of QI metrics in the strategic planning process, as we previously talked about. And board members should get involved in the discussion when QI data is presented. If you don't understand as board members, you need to ask questions. So now we're going to talk about some factors that you need to consider when gathering and presenting clinical quality data. You need to think about the background, skill set, and culture of the board. What's the primary language of your board members? What's their educational level? And what's their professional background? Some boards that I see have a high number of professional executives on them. Others just don't. So you need to factor that in when you're determining how you're going to present data to the board. You also need to think about the learning style of the board. Once again, is the board more visual? Is the Health Center staff more visual? Is it easier if you put metrics into dashboards so the board members can take a look at that? You need to consider the method and frequency of data collection and reporting, and we'll go back to that, who will present the data. As I mentioned, I sometimes see it's a CMO or a medical director. On the flip side of that, I also see where the medical director attends the board meeting, but it's actually the director of quality that is presenting the QI report. And what you want to think about is the presentation style of the person who is presenting the data. Is the board going to engage better with the presentation style of your QI director? That may be the case, so you want to factor that in. Once again, think about what format the data is going to be presented in, and you also need to consider the training tool that you're going to use when you train your board members. HRSA has a really good quality toolkit on their website. At the end of the presentation, I've included a link to that toolkit. You also want to think about using a Plan, Do, Study, Act or a PDSA cycle sheet as one of your training tools. so that the board knows exactly what the process is if you've identified a metric below the benchmark and you're trying to make a change. And also use the operational site visit guide as a training tool. I've seen some CEOs that routinely do training on the operational site visit requirements. They take one requirement and go through it at each board meeting, or they may go through it on a quarterly basis. But use that operational site visit guide because it will tell you every single thing you need to know. What I've included here is a sample PDSA worksheet. And then finally, let's talk about some strategies for gathering and presenting clinical quality data. So first off, you need to be sure that you have a plan for data collection. The health center needs to have a plan as to what data is going to be collected, how it's going to be collected, when it's going to be collected, why, and exactly how much data is being collected. You want to consider multiple data collection methods. I know that a significant amount of data is collected in the electronic medical record now. If you're using an EHR that just does not support the reporting functionality that you need to report UDS and other metrics, you need to think about the possibility of a data analytics tool. Think about using other methods of data collection, because it's not going to do you any good to collect data that is not valid. Certainly patient satisfaction is typically collected via a survey, and also chart audit. Even if you're collecting and reporting your data through your EHR, you need to be sure that that data is valid. You still need to do some manual chart audits on that to make sure that the data that you're reporting is accurate. Another strategy is to standardize the process. I can't stress that enough. I'll use the example of the patient satisfaction survey. Certainly you're going to use a standard survey tool. For chart audits and peer review, same thing. If you're doing manual peer review and chart review, use a standardized form. Now, certainly for peer review, you're going to want to have a form that is appropriate for the specialty. Same thing with medical record review, though, as well. You're going to want a standard form for OBGYN, a standard form for peds. Once again, make sure that data is reliable. You're going to have to go back in there and do some manual medical record review just to validate. And then lastly, act on it. You need to act on the data. It doesn't do you any good to just collect it and not do anything with it. And from a HRSA perspective and a reviewer perspective, I look through, I will tell you that I typically ask for between 6 and 12 months of QI meeting minutes to review. And I know the admin governance person, the admin governance consultant typically asks for between 12 and 18 months of board meeting minutes. So both sets of those minutes should tell me, as a reviewer, a story. I should see that you collected that data and that you implemented a PDSA cycle and that changes were made based on that. In these next couple slides, I've just included a couple of examples of different formats that you can use to collect data and report. This is a sample patient satisfaction survey. And as you can see, this is a very good visual to present, not only to collect the data, but to present it to the board, much more eye-appealing than a narrative would be, as well as a sample bar chart. So you're going to want to report results in a format that's easy to understand. I can't stress enough, you want to show trends. As health center staff and as board members, both groups of individuals need to see where you're improving and where you're not. And if you're not trending your data, there's no way to identify that. Once again, discuss the results. And this applies to both health center staff and to board members. Talk about those results as well as ask questions. Health center staff are going to want to address any training needs on the part of the board members. And as I mentioned earlier, board members out there, if you're feeling like you need additional training, you just need to ask for it. Certainly identify strategies for improvement. We talked a little bit about implementing a PDSA cycle for metrics that are below the benchmark. And once again, the common theme throughout this webinar is document, document, document in meeting minutes. Because if I don't see that information in there and the admin governance consultant doesn't see that information in there, it's going to make program requirement number 17 a not met. I've included some additional resources here for you all. You'll see that I included the link to the HRSA Quality Toolkit. And I've also included the link to ECRI, the ECRI Institute. They have some really, really good quality tools and some good quality information for both health center staff and for board members. Subscription to ECRI is free for all health centers. So I strongly encourage you to utilize that resource. So that's kind of a summary on, some different approaches to presenting quality data to the board. I'm hoping that, just going through the webinar and kind of brainstorming has helped to give you some additional information and, some additional information for you to think about. Think about the way the health center is presenting data to the board. And board members, think about the way that you're receiving it. Maybe you need to make some changes. At this point, I'd be happy to entertain any questions and answers that anyone might have.
Thank you so much, Michelle, for this thorough presentation. We are going to start the Q&A session. If you would like to ask a question, please submit it through your question box on your control panel, or if you dial in through your telephone and would like to verbally ask the Michelle question, use the raise hand icon on your control panel and your line will be unmuted. And I also would like to remind those attending the webinar to please complete the post survey. That helps us to improve our webinars and get additional information on the topics that you want us to include in the future. Now, we have a couple of questions. I believe that I will have to answer the very first one in regards to a copy of the slides. After the webinar, we are going to send the slides to all attendees, and the recording of the webinar will be posted to our website, www.nchph.org. Now, the first question that I have is for peer review. What if we only have one provider in a specialty? We only have one pediatrician.
Okay, so my response to that, and I always, and trust me, you're not alone in this, a number of health centers struggle with this. Typically what I do is I encourage the health center to outsource. Maybe there's a local hospital that is willing to perform that peer review, or another provider of the same specialty within the community who is willing to perform that peer review. There's places that you can outsource any type of peer review to. I know that can get expensive, so my first recommendation is always to try another provider within the community.
Great. Thank you so much. We have another question. Can a clinical director be an RN?
Well, clinical director, as far as the QI program, there needs to be oversight by a physician. Okay, certainly the director of quality or the QI coordinator. I typically see that individual as an RN, but the clinical director I typically see as the medical director providing oversight.
Great, thank you so much. There is another question. If the meeting minutes reflect the quality report, does a copy of the report need to be included in the board packet as well?
Yes, I strongly encourage that. So include the QI, a copy of the QI report in the board packet. I'll tell you, as a reviewer, I look through all the packets because a lot of times that's typically the only place I can find any type of QI, any type of QI data that's going to the board. But not only does that report need to be included in the packet, it also needs to be, the discussion about that report needs to be clearly documented in the minutes.
Excellent. Thank you so much, Michelle. I just want to remind that the slides will be sent to all attendees after the webinar has finished. We have that question. And the recording will be posted to our website, www.nchph.org. The next question. We have a monthly QA committee meeting that is made up of board members, and a copy of that committee report is submitted to the board each month. We also have a quarterly report that is done to the full BOD live at the meeting. Is this acceptable and meet the requirement?
So, Jose, I need for you to clarify for me. So it sounds here like there's 2 QI committees. Is that correct?
That's what I understand for the question, but we can ask Lori to clarify the question for us.
Okay, it sounds like we're talking about having like an internal QI committee and then a board QI committee. That's my understanding. But if she could clarify that, that would be helpful.
All right. So let's wait to see if Lori can update the question so we can read it later. The next question, you stated that the board must review and discuss QA data presented every month. What if the board approved QI manual states that QI committee meets every other month and only reports every other month to the board?
From a compliance perspective, you will certainly meet your FQCA requirements because for that application you need to only send in 6 sets of meeting minutes, QI meeting minutes, but there still should be discussion. I'm assuming that if you're taking a look at metrics and you're identifying those below the benchmark, that a PDSA is being implemented, and that should be discussed. Even if a full report isn't given every single month, we need to see progress. When we look in those minutes, we look to see progress. And like I said, it needs to report as a story.
Great. Thank you so much. Then we have the clarification of the previous question. Lori says that it's one committee and it's a board QI committee, but she says, but we also do a live report at the meeting quarterly, while the monthly meeting minutes are just part of the consent agenda and don't have much discussion.
Okay. So I would suggest beefing those minutes up a little bit so that the discussion is more clear, because that's certainly something that I'm going to look for.
All right. Thank you so much, Michelle. The next question. You stated the board must review and discuss QI data presented every month. What if the board approved QA manual states that QA committee meets every other month and only reports every other month to the board? I'm not sure if I read that one.
Yeah, I think we answered. We already answered that one, but I can, if you'd like me to answer it again, I would be happy to.
All right. In case it came from another person, Michelle, I believe that we have to answer that one too.
You would like me to answer that one?
Yes, please.
Okay. As I mentioned, certainly to meet FTCA requirements, you need to submit 6 sets of QI meeting minutes in order to obtain your coverage. But if there's active discussion going on with the board, let's say the report is only presented to the board every other month. I'm assuming that if you're talking with the board about metrics that are below the benchmark, that you're implementing a PDSA cycle, and then I would expect the next month for there to be some updates. I mean, I need to see, that progress is being made, that you're actively working on improving those metrics. Those minutes need to tell me a story.
Okay, and I believe this is there is some kind of confusion, Michelle, because I believe this is a similar question. Is there a requirement for monthly reporting to the board? We currently report quarterly, which was adequate per our 2015 OSB.
And that may be the case. It may have been adequate. I think, as all of you know out there, the results of your operational site visit are kind of dependent on the dynamics of the team. They certainly should be following the site visit guide. And is it absolutely required? Does the site visit guide tell you that? No, it doesn't tell you that it has to be monthly. What it does tell you is there needs to be, quote unquote, routine and regular reporting. From a best practice perspective, I look to see that that's happening monthly. And as I said, does it need to be a full report? It doesn't have to be a full report. I would absolutely expect to see a full report at least every other month. But on a monthly basis, the board should be getting some updates on quality issues or quality processes that are being implemented.
Great. Thank you so much, Michelle. This is I believe she has 2 questions. Let me read it. If board credentialing and privileging approval is delegated, who can this be delegated to, and what if the board's ongoing role after the responsibility is delegated?
So if I don't see this, I will be honest and tell you, I don't see delegation of approval very often, and I encourage you to be very cautious with that. An appropriate person to delegate that approval to would be your chief medical officer. But even if the CMO is performing that approval, even if the board is, even if the CMO is performing that approval, the names of those individuals should still be presented to the board.
Yeah. Can you please tell Ms. Virginia to maybe contact somebody? Sorry, Michelle, but there is a noise here, a background noise here in my office. Just let me see if I can make this person get quiet for a moment. In the meantime, for those who are asking for the website, we are sending an email with the slides, and the information on where you can get the recordings will be in the email. But the URL is www.nchph.org. The next question. A member of the board quality committee attends our QI meetings and is provided with minutes and summary for his presentation to the board. Would you recommend that the QI director attend the board meeting and take over the task of the report to the full board?
So, I don't think that necessarily has to happen. I would suggest that individual attend, maybe a quarterly board meeting. But if you feel confident that information is being distributed to the board, that board member is essentially the liaison to the board from the QI committee to the board. So if you feel confident that that information is being presented and discussed, I'm fine with that. But from a best practice principle, I would expect that attendance by the quality director occur, maybe quarterly, every other month or quarterly.
Great. Thank you so much, Michelle. The next question. Is there a requirement to have a board CQI committee?
No, there is not. There is not. And I will tell you that many small health centers struggle with that piece because, as you know, that some of the larger health centers have an internal QI and then a board QI committee. It is not a requirement. What the requirement is that the information gets relayed and discussed to the board. So those health centers that have a board QI committee typically, they typically use that committee as a liaison from the internal to the board.
All right. Thank you so much, Michelle. And I just typed the URL www.nchph.org for those asking where you can find the recording after the webinar has finished. Now, the next question, in terms of peer review, we recently branched into behavioral health services. Should we do a peer review on the LCSW?
Absolutely. Absolutely. I should see peer review being done between providers within the same specialty across for all services and scope.
Great. Thank you so much. Next question. I am a member of our quality team, and we have a community health center board. Are you saying that the documentation of minutes regarding data metrics reviewed has to happen at the board level?
Yes, and I'll use the example. This is typically an example I do with the health centers. If you're struggling, the reason that needs to happen, like your UDS metrics should be reported to the board, your clinical performance measures. For example, a health center may be struggling with the diabetes metric. So I would expect to see is that's being presented to the board, it's being discussed, and then possibly a conversation I might see documented in the minutes is maybe we need to consider bringing up a podiatrist 2 days a month. So that's the kind of stuff that I'm looking for.
Great. Thank you, Michelle. Next question. We share and discuss our QI report at the board meeting monthly and are a part of the board packet. Does the entire QI report need to be included in the minutes, or do we just need to include the discussion in the minutes?
I'm sorry, Jose. I need for you to repeat that question to me.
Sorry, Michelle, something happened here. So if the person, I'm going to ask the person who sent that question to resend it. I cannot find it in the list in the queue anymore. So could you please retype your question so Michelle can answer your question? I'm very sorry. Next question. We report to the board monthly. We report metrics that need trending, clinical indicators, access metrics, quarterly. Other issues, credentials, patient satisfaction, keeping people safe are reported monthly. Is this satisfactory?
Yes, yes. I mean, so long as there's some discussion that's happening on a monthly basis about QI initiatives, yes, I'm fine with that.
Okay, good. Now, when you say data has to be presented to the board, do you mean to the governing board or your QI committee members, which also have some board members as a part of it?
No, it needs to be presented to the board as well, to the board of directors. For that reason that we just discussed, if metrics are not meeting benchmarks, HRSA starts to look at that, and they want to know what's being done to correct that. And it's the board's responsibility. The board has ultimate approval authority for the QI plan, so the board needs to know that information.
Okay, this is
they should be making.
Sorry, go ahead, Michelle.
They should be making decisions based on that data.
Great, thank you so much. And this is the question that she's resubmitting the question now, Michelle.
Okay.
She said, we include our QI report in the packet and discuss it monthly at the board meeting. Do we need to include all the text from the report in the minutes, or do we just need to include the discussion about QI in the minutes?
Okay, I understand now. Just a discussion. So long as the report's included in the packet, I just want to be sure that there's discussion about that report.
Excellent. The last question that we have is, are there specific guidelines for financial QI similar to clinical?
That's a good question. I don't know the answer to that. I'm sorry, my expertise is in the area of clinical and not fiscal. Maybe that's something we can talk about, Jose.
Okay. And if we're gonna try to find additional information on this, and if we find any resources, then I will send this answer directly to Rose via email.
Okay.
And I believe we don't have any other questions in the queue. So thank you, Michelle, again for this wonderful presentation. I want to thank you one more time. To all of attendees, please complete the post survey. This helps the National Center for Health and Public Housing to improve our webinars. Also visit our website, www.nchph.org, and you will find archived webinars, publications such as training manuals, fact sheets, newsletters, information on our annual training symposium, and information on how to submit one-on-one training technical assistant. You can also join our mailing list and receive HRSA updates, Medicare updates, funding opportunities, information on senior programs, and information on the upcoming webinars. You can also follow us on social media, Twitter, YouTube, and Facebook. And if you have any questions, you can also contact our staff members. And thank you once again for attending this webinar. And thank you, Michelle, for this thorough presentation. Have a good afternoon.
Thank you.